several years now, and he was also the first physician to teach me about MCAS. I'd also like to acknowledge Dr. Larry Afrin, who's the leading expert in MCAS out of the US. His background is hematology oncology, and he's quite possibly the most accessible specialist I have ever reached out to. He's very clearly dedicated to his patients, but also to advancing medical knowledge by sitting on journal editorial boards. He directs fellowship education in hematology oncology, and he reaches out to physicians one at a time regularly. So he's been remarkably helpful in promptly answering questions as I prepared for today's talk. So my objectives today will be to help you first off remember what a mast cell even is. We'll look briefly at mast cell disorders as a whole so you can understand what MCAS, the syndrome, is under that umbrella. We will discuss current diagnostic issues and what these patients clinically look like. And I hope you may even consider initiating management, and I will be providing you with additional resources to support you with this. And as this is a pain medicine talk, I'll draw your attention to why this is critical in our practices in pain and why it matters in our research setting. I'm going to start with a bold statement that almost 100% guaranteed you have all seen MCAS patients, and I have a hidden objective in the talk today in recruiting my colleagues to recognize and treat MCAS. I think it's working now. Okay. So it's blocking some of the screen? Yeah. Okay, so sure. Hang on, everyone. Sorry about that. Okay, so let's do that. Okay. And then share screen again. That was the one we had problems with before. So I did this one. Okay. Yeah. Okay. All right, so hopefully that's better. Okay, moving right along. So to borrow a conceptual slide from an MCAS presentation of Dr. Afrin, there is a tale that we have all heard about, blind men examining an elephant, in which each sees the elephant in a different way. So I provocatively titled this presentation The New Fibromyalgia, because as pain clinicians, we are frequently sent patients for a pain issue that is really just one piece of a big medical puzzle that collectively in the medical community, we're not recognizing. So I want to challenge each of you to become aware of this condition. As often the case when patients arrive at a tertiary pain center, we are the last stop in a long line of specialists that have been unable to help such patients. And we too become prey to putting patients into little boxes that just don't quite fit, especially when the patients are medically complex or they just have weird symptoms that we can't explain. So we try our usual treatments and become part of the overall system failure, especially when those treatments do not work. So I want to invite you all today to see the whole elephant. I also refer to this as the new fibromyalgia because, as with any new clinical entity, there is substantial medical community skepticism about the validity of such a diagnosis, after which time actually shows it's a real thing. So much like we did with fibromyalgia, we've also done this historically with whiplash disorders, which initially was thought to be a somatization issue, and now such patients can often do quite well with pain interventions. And we did this initially with the newer concept of the microbiome impacting psychiatric health, pain, and lots of other medical issues. And we're only beginning to scratch the surface of the microbiome. And it's also the new fibromyalgia because perhaps by the end of this talk, you will agree that a subset of fibromyalgia patients may actually in truth be MCAS patients. So to ease you in with a basic patient profile, the typical MCAS patient is medically complex with a history that sounds kind of autoimmune, systems consistent with systemic inflammation, and weird sensitivities or reactions to things. So I'm going to present to you all Pandora, a possible case of MCAS. Pandora is a 53-year-old female accountant I saw in August who was referred by rheumatology for chronic paresthesia, allodynia to her right face, and then the entire right side of her body, with a query of post-herpetic neuralgia. Her past medical history was significant only for migraines from the age of 10 and herpes zoster at the early age of 41 in 2007. Her worst issues started about 4 years ago when she woke up one day and had right arm weakness. She simply could not lift her right arm. This persisted and gradually also became increasingly painful, limiting much activity. So she pursued physio and chiropractic care and community, but despite this, progressively worsened. So after about 3 months of this, she finally went to see her family doctor, who ordered an ultrasound that showed bursitis to both shoulders, and she was told this was self-limiting. The pain continued to worsen, though, and it spread to her right face, then right hemibody, and then globally by about 1 year, with the right worse than the left. The pain's burning and itching in nature, and she feels like she's constantly on fire. Then by about 6 months, she noted a hoarse throat, dysphagia, and burning, and she began experiencing these weird choking episodes. She was treated with antibiotics twice, but with no meaningful resolution. And although it sort of settled somewhat, it continues to ebb in and out of her symptomology. Around this time, she also began experiencing electric shock sensations that would wake her from sleep. And on one of these initial episodes, she presented to the emergency department because the right side of her face was numb, and it's remained numb ever since. By 1 year, she began having abdominal symptoms of extreme burning pain that was associated with nausea and diarrhea. GI scoping was negative except for findings of mild inflammation. Consults have included rheumatology, for which workup was negative. One neurologist thought this might be hemicorpalgia secondary to her migraines, and started her on Aimovig, a CGRP antagonist, about 1.5 years ago. While this dramatically improved the control of her migraines, her global pain did not improve and continued to wax and wane with a trend to the worse. Stopping Aimovig did not improve her symptoms several months ago. Infectious disease was consulted, and she was found to have antibody titers for Epstein-Barr virus, but no active mono, and she had negative Lyme disease and CMV workup. The patient began having rashes to her face, with some lesions appearing vesicular, but in a non-dermatomal pattern. She began to have flushing and hives on occasion to unknown triggers, and she began photo documenting this evidence, as she would often present to the doctors, having had resolution of these before they could be examined. Then she thought, well, given the burning nature, she thought maybe this could be shingles, her previous shingles, but representing without the rash. She had a lumbar puncture, and it was negative for herpes zoster, but despite of this, underwent treatment with valacyclovir, and after 6 months still had no improvement overall. She was assessed by physiatry and had negative EMGs and no concrete findings explaining her symptoms. She was also assessed by psychiatry, but no psych disorder, including somatic disorder, was found. So her pain has progressed and is accompanied by overwhelming fatigue and increasing difficulties concentrating. Some unusual symptoms emerged, as well as regular presyncope, palpitations, belching, and vomiting. Finally, despite trying or pursuing any investigation or therapy suggested by any physician and allied health professional, she's been denied disability benefits because of a lack of diagnosis that would explain the supposed severity of her symptoms and the inability to function in her job. There's lots of other details that I've left out for the sake of time, just to give you a sense. Okay, so most of you are probably thinking, let's back the truck up, start slow. What is a mast cell? Now, if we think way back to medical school, this diagram invariably should evoke some fond memories of your hematology lectures, am I right? So the mast cell on the left there is part of the myeloid line alongside erythrocytes, thrombocytes, and cells that are part of our innate immune system, like neutrophils, basophils, eosinophils, and macrophages. So interestingly, some blood cell line pictures don't even include the mast cell, which I discovered when trying to find a picture that had one in it. And that's because they're actually in pretty low numbers, really. Like if you did a differential, neutrophils are about 65%, lymphocytes 25%, monocytes 6%, eosinophils 3%. of which most of us learned about mast cells in med school, in which we learned mast cells are involved in type 1 hypersensitivity reactions. Whereas the more learned immunity is much more refined, closer to bullets being delivered to a target. Now, when an antigen stimulates mast cells to explode, the technical term being degranulate, the typical symptoms will affect multiple organ systems. And that, in fact, is part of the criteria of anaphylaxis, that 2 or more organ systems have signs or symptoms. And these symptoms, the typical ones, are listed here. Now, the kinds of chemicals released by mast cells are known as mediators, and ongoing research has shown there are over 1,000 such chemicals involved in mast cell biology. Mast cells have over 200 receptors. The ones we know about the most are listed here, with histamine, tryptase, and heparin being the most specific to mast cells and the best understood, if that can even be said. Tryptase has been identified as more reliably elevated in anaphylaxis patients, but using this as a marker also has the problem in that about 4% of the population has something called familial hypertryptasemia. So that definitely affects its utility in diagnosis. You have to rule out that condition. There are loads of cytokines, prostaglandins, leukotrienes, and other pro-inflammatory chemicals in these cells. So although they're best known for their role in allergy and anaphylaxis, mast cells play an important protective role as well. So they're involved in wound healing, angiogenesis, immune tolerance, defense against pathogens, and vascular permeability. So histamine dilates post-capillary venules, activates the endothelium, and increases blood vessel permeability, which can lead to local edema, warmth, redness, and the attraction of other inflammatory cells to the site of release. It also depolarizes nerve endings, which can lead to itching or pain. Mast cells serve the same general functions in the body and central nervous system, such as affecting or regulating allergic responses, innate and adaptive immunity, autoimmunity, and inflammation. And across systems, mast cells serve as the main effector cell through which pathogens can affect the gut-brain axis. So having said all that, this diagram is a gross oversimplification in which the ways in which aberrant mediator release can affect a few symptoms. So before I dive into MCAS itself, I want to clarify from the get-go that MCAS is not equivalent to systemic mastocytosis. Systemic mastocytosis is a mast cell disorder that really behaves more like a neoplasm and is diagnosed with bone marrow biopsy showing abnormal numbers of mast cells, very elevated tryptase levels, and flow cytometry looking for a very specific gene mutation. It is a rare disorder, but symptoms of systemic mastocytosis and MCAS clinically are similar. So that makes this confusing when you're trying to initially discuss MCAS with those clinicians perhaps more familiar with systemic mastocytosis and its variants, the variants being listed in the small writing. I think it's also really important to say that MCAS is not multiple chemical sensitivity syndrome. Again, symptoms might be similar, and this is considered a somatic disorder. MCAS is a condition that has verifiable lab findings, albeit they are difficult to obtain, as I'll explain to you shortly. But ultimately, I also wonder if, as MCAS becomes more widely known about, if patients with multiple chemical sensitivity will by and large be found to actually have MCAS. Time will be the judge. Okay, to stop beating around the bush, MCAS is defined as a chronic, inappropriate, non-neoplastic mast cell activation, so activation being the key word, resulting in multi-system inflammatory phenomena, plus or minus allergic symptoms, not fitting other defined allergic or inflammatory diseases. To conceptualize this briefly, what we actually know about mast cell disorders really just represents the tip of the iceberg. And MCAS in this family at this point in time is not largely well understood. And this schematic also helped me, or helped my brain at least, understand under the umbrella of MCAD or activation diseases, that systemic mastocytosis, although the best understood, is exceedingly less common than MCAS. With regards to epidemiology, numbers will vary across the world and between studies, but overall, allergies affect up to 30% of the population, although some areas will say even up to 50%. Now, where systemic mastocytosis may affect 2.7 people in 1 million, studies looking at overall prevalence of mast cell activation diseases in Germany have cited 5 to 10% of the population is affected. And depending on the diagnostic criteria used, one study hypothesizes up to 17% of the general population has a degree of MCAS. Now, where the true prevalence lies remains to be seen, but think about even a 5% prevalence. This would have major implications for the medical field. So I'm going to try to paint a clearer picture. Features of MCAS require that the overall mast cell load is normal, so the numbers are normal, but the condition is that there's aberrant activation. Now, because mast cells reside in literally every organ system in the body, symptoms can present in any tissue. The typical course of the syndrome is waxing and waning of symptoms over the person's lifetime, typically with a staggered progression. There seem to be groups of patients that recall symptoms throughout their entire lives, whereas others note symptom onset after a trauma or infection. These folks have a normal life expectancy, but quality of life can be low, and dysfunction and disability are common. To keep the pathophysiology of MCAS as blissfully short as possible, the bottom line is there's mutations in tyrosine kinase proteins, known as KIT for short, which are theorized to be a somatic clonality, not germline, meaning it's not really inherited, but yet at the same time, it seems to run in families. So there's also some discussion that there may be some kind of fragility gene that's passed on, allowing for somatic mutations to occur should there be some kind of environmental insult. The mutations are gain of function mutations, in which it's hypothesized that there's a decreased threshold to activate mast cells and therefore degranulate and release all their fun chemicals. The other aspect is that some mutations may cause the increased production of certain mediators, but not others, which may account for the heterogeneity in which the syndrome presents, given the number of KIT mutations that have been found in MCAS patients thus far. So the low-hanging fruit in recognizing MCAS in the MCAS world are patients with idiopathic anaphylaxis and urticaria pigmentosa. I'd seen 2 of these patients during medical school alone before learning about this, and now I think back and wonder if they might have had MCAS. Also, I find that something I've seen repeatedly in the literature, both lay and scientific, is the theme of weird or bizarre case histories. That's usually what makes me at least start to consider it. Now, I'm not going to read out all of the tables I provide in this presentation. They're just here for demonstration and for your reference after. But to highlight from this one table, note the multi-system nature of the most frequent symptoms. And especially for the pain physicians, note in the neuropsych category the symptoms of headache, neuropathic pain, and polyneuropathy. And the MSK category, note muscle and bone pain and migratory arthritis. So before we enter the quagmire that is diagnosis, I'm going to highlight a reasonably well done study on 413 patients who met criteria for MCAS with clinical symptoms and lab or pathology evidence, in which 298 of the 413 were retrospectively analyzed and 115 were prospectively analyzed. And they were looking for the typical symptoms or what described these patients. This ridiculously busy table highlighted all of the symptoms reported by at least 10% of the patients in the study. I went through and highlighted the symptoms that occurred in at least 30% of the patients. And I guess they must have realized that most of us can't read writing this small, so they made a much nicer table. Now, this table lists in order of frequency the most common symptoms. So you'll note our usual suspects of fatigue, fibromyalgia type pain are right at the top. And then pre-syncope or syncope, headache, pruritus, paresthesias, nausea, vomiting, chills, edema, eye irritation, dyspnea, and reflux occur in more than half of the patients. There are many other symptoms that we see in pain medicine that also make this list. Now, in that same study, they found that most patients had been experiencing symptoms from the median age of 9, and on average had 11 comorbidities that were inflammatory dominant, and on average were experiencing 20 symptoms. Based on multiple previous studies done by one of the expert hubs out of Germany, a validated questionnaire has been published that will not only help us complete a history on such patients, but also guide laboratory and pathology diagnosis in these patients. A score of 8 to 14 implies a degree of mast cell activation, and a score over 14 clinically verifies MCAS. It consists of a combination of clinical signs and symptoms, laboratory parameters, and imaging. A quick word, though, before we explore diagnosis. I've actually given this talk 4 previous times to various physician groups, and I was completely oblivious before to the war in the literature on the topic of diagnostic criteria. Having had the personal experience of trying to work up such a patient, I am now painfully aware, having done a deeper dive than ever before, of the cat fight that 2 groups of hematologists are having. And if this wasn't so important, it would actually kind of almost be entertaining. So one example I'll give you is I looked at reference lists and authors commenting that those references marked with a star were considered to be more important. Of course, these references starred were their own. So to summarize the 2 approaches, the first group has leanings toward only considering MCAS in subjects with more anaphylactoid symptoms and publishes more heavily in the allergy and immunology world, whereas the second group considers MCAS more broadly. I think both are useful in understanding the syndrome, but if I will weigh one more heavily, it'll be the second for reasons that I hope to make clear to you. So, the valent criteria, originally published in 2010, requires symptoms from a restricted list shown there in 2 or more organ systems. They need to show an elevation in tryptase level from baseline by 20% plus 2 nanograms per mil within 4 hours of a flare onset. And finally, there should be response to drugs targeting mast cell mediators. So criticisms of this have been cited as being too restrictive in the symptoms considered, which, if reviewing the previous characteristics study I showed in the table, would exclude fatigue, muscle pains, and many other extremely common neuro symptoms. Now, with tryptase being one of only many mast cell markers and typically only likely elevated to that degree in patients with anaphylactoid symptoms, it misses a large cohort of probable MCAS patients. And it's also really confusing to interpret because it requires the tryptase level to be interpreted within the normal range. So that this means that even though less than 11.4 is normal, you could have a positive MCAS result if you had a baseline of 5 and a flare result of 8, as an example. Moreover, there's actually no research data to support the numbers used for the 20+2 requirement, and it seems to have been pulled from an expert consensus only rather than proper studies. It's also really quite difficult for patients logistically because first, they feel extremely unwell during a flare, and then even with a requisition in hand, to present to the emergency department or walk-in lab services within 4 hours, to have labs drawn without resistance from receiving physicians is a huge challenge. And then you add to this that tryptase peaks within 15 to 60 minutes after anaphylaxis, with a 2-hour half-life. So labs that aren't drawn right away are unreliable for interpretation. And then patients without anaphylaxis, but with possible mast cell symptoms, are likely to be negative. Then the last criticism is that making response to treatment a criteria for diagnosis is really like putting the cart before the horse. Now, this group did publish some minor updates in 2019, but it doesn't really improve on any of these flaws. Having said that, if my patient suffered with anaphylaxis, I would still consider this approach. Okay, so the Molderings criteria. Published in 2011, they consider a broader array of laboratory parameters, and it requires either fulfilling both major criterion, which are you have to find mast cells in bone marrow and or GI-GU biopsies. And the second one is they have a clinical constellation of symptoms consistent with mast cell activity. So it's either you have fulfilled both of those major criteria, or you fulfill the second major criteria and any one of the minor criteria that are listed here. So this list at least gives various specialties options within their means to contribute toward the diagnosis of exclusion or exclusion of MCAS. My complaint is that even with the option of other lab tests, these are actually still difficult to obtain as they're not offered in every lab. They require great care and proper collection, and many need to be chilled as several mediators rapidly deteriorate at room temperature within minutes. They also compromise, though, by giving a nod to the first group with the option of response to mast cell inhibitor treatments. Of the most accessible tests in number 4 there, tryptase and chromogranin A are at least stable at room temperature and are available at our lab. Now, I've already discussed problems with relying on tryptase. Chromogranin A is useful for diagnosis, but only if you've ruled out the possibility of a pheochromocytoma, carcinoid tumors, person's not on a PPI, and they don't have kidney or cardiac disease, all of which could elevate chromogranin. But most of these problems can be easily ruled out clinically with history and without extensive further testing. Now, most of the other blood tests have to be collected in chilled test tubes and painstakingly kept chilled. Heparin, as an example, at room temperature has a half-life of 30 seconds, histamine 2 minutes, and most of the others have about 1 minute. Now, heparin is actually quite useful in that, along with tryptase, it's more specific to the mast cell, and we're able to measure this in our lab. The only other cells in the body that secrete heparin are basophils, and mast cells that function normally secrete 1,000 times more heparin than basophils. So it is more slanted toward mast cells for sure. Criticisms of this approach have been that this may result in overdiagnosis. So for example, I already mentioned the problems with chromogranin A, but given the harms of underdiagnosis when possible effective initial treatment is reasonably simple and with minimal harm, the much larger group of MCAS researchers tends to favor the Molderings criteria. And as with other diseases, I suspect that the pendulum between over and underdiagnosis will swing quite widely as we learn about this disease and continue to refine the criteria. Now, where the two hubs of expertise do agree is that symptoms should be consistent with mast cell activation, with flares or waxing waning patterns, that 2 organ systems are involved, and that no other disease accounts better for the full range of findings. This schematic, which is not to scale, does give another conceptual way for you to understand the overlap of disorders, and also to point out that idiopathic anaphylaxis patients really only constitute but a portion of the overall MCAS population. Okay, so what about Pandora? Well, I applied the clinical questionnaire to her case, and without any lab or imaging findings, she scored 29. Recall that greater than 14 was a clinical verification of MCAS. Now, initially, all I ordered was a tryptase level and instructed the patient to come for a repeat blood draw during one of her choking episodes. Although it was elevated, it was not significant per the valent criteria I was initially relying on. Because I was not aware of the limitations of the criteria, and this is what I previously had presented as consensus criteria, I actually told the patient at follow-up that I did not feel she met criteria for this diagnosis and I'd have to rethink her case, despite the fact by that point she had started to feel a bit better on the cetirizine that I'd started her on. In researching for this presentation and in reaching out to Dr. Afrin, the hematology expert on MCAS, I realized the limitations of the valent criteria I'd been using, so I added a few more tests. Now, unfortunately, her samples were not properly chilled, despite requesting that they be chilled, and the plasma histamine was ultimately discarded. The chromogranin is still pending because apparently it takes a month to get results. But the plasma heparin was interesting. It came back at 0.1, and I was very confused by the results because the reference range is 0.3 to 0.7. And at the time, I didn't realize that the reference range was for patients being actively treated with heparin, which in retrospect makes total sense. Now, the actual endogenous level of normal patients with a normal heparin level is 0.02. So despite the fact that her heparin was not chilled properly and had probably deteriorated to far lower than its true value, Pandora's heparin level was 5 times the normal level. So treatments. Treatment is certainly multi-pronged, but the emphasis in the literature is that MCAS overall can be a very treatable condition with some patients and trial of various mast cell mediator antagonists and inhibitors. So this includes a base of H1 and H2 blockers for most patients, mast cell stabilizers, and then other options such as leukotriene antagonists, cyclooxygenase inhibitors, and in more severe cases, considering tyrosine kinase inhibitors or anti-IgE therapies. Supplements are also apparently helpful in the literature, and interestingly, I'd never heard of either slow-release vitamin C or quercetin, and I've seen both published this year in an ICU protocol for treating COVID patients. So I thought that was interesting, but that's a rabbit hole for another day. Emphasis is also placed on not giving up on an entire class of meds if one trial of a med is not effective or not tolerated. And it's realistic from what I read in the literature that most patients can expect not only improved symptom control, but also significant return to function. So with Pandora, she's actually a perfect patient for me to have as a possible first MCAS patient. As an accountant, she's been keeping spreadsheets since our first meetings of her symptoms profile, because she found writing out her symptoms manually in a diary for me was quite tedious. So I had started her on twice daily cetirizine, and she reported a modest overall improvement of about 30% of her burning pain, the stinging and itching she experiences. The electric jolts that wake her from sleep have stopped. And then I opted to see if I could do better with diphenhydramine. It was dramatically better in terms of pain, almost 50%, but after less than a week, oddly, she found it was triggering her migraines every other day instead of the 5 per month she would typically have. So she resorted back to cetirizine. And then I recently started her on ketotifen in the last couple of weeks, so I have yet to see what the result of that is. There are other meds as per the list that I'm going to consider, but I'm going to add them very slowly and one at a time to determine whether there's any true benefit as we go along. So obviously the big question will be whether I commit to this diagnosis or not, and I recognize that although technically I may have met criteria, this is an unknown syndrome. And given the possible conflict she may have with her insurer about her disability claim, I would really prefer to try and obtain more results confirming this. And I've also been hoping to find another physician that would provide a second opinion, given that I'm a far cry from a hematologist. But this is proving to be a challenge, as I really had no idea how little known this condition was, as I had this taught to me as a medical student, and it's just part of my medical repertoire. But reaching out to the specialist in the States, apparently there's only 3 physicians in Canada that outwardly or specifically will treat MCAS patients. So that's just great. Overall, I'm cautiously optimistic though, based on the literature, that if this is the correct diagnosis and optimal treatment is found that stabilizes her MCAS, I see no reason why she would not be able to return to work as she wishes to. So I realize that I've probably really killed you all with a topic way outside of our usual comfort zone. So I want to finish with more specific food for thought for pain medicine clinicians. This paper was published in 2016, and it's a really interesting read on the mechanisms in which mast cells influence nociception. Now keep in mind, this was written by hematology oncologists, not pain clinicians. So perhaps those of you who are experts going through this paper, you may not find that the things that we focus on in pain medicine really go together, what they say, but I think we should take it with a grain of salt and respect them sticking their necks out into the pain world. Now, the main point that I pulled from this paper is that a lot of chemicals we research extensively in pain medicine not only stimulate mast cell activation, but some are also produced by them. So substance P, CGRP, they stimulate mast cells, as do cytokines, histamine, and prostaglandins. There's also toll-like receptors on mast cells that can be triggered and cause inflammation through that pathway. And the inflammatory soup is highly influenced by mast cells. Mast cells are a part of the neuroimmune interface, with mediators stimulating the release of substance P and CGRP, as mentioned, and those in turn stimulating further degranulation in a vicious cycle. Now, this paper goes on to postulate ideas about how mast cells may be connected with various pain syndromes, and they focused efforts on migraines, fibromyalgia, pelvic pain disorders, cancer pain, and CRPS, to name a few. There have been studies already done that show increased mast cells in skin biopsies of fibromyalgia patients and higher levels of certain interleukins in fibromyalgia patients. So that really made me wonder about the directionality of these conditions. Recall Osler's quote, "It is much more important to know what sort of patient has a disease than what sort of a disease a patient has." So I've done a lot of reflection on fibromyalgia in the last few weeks. To be honest, I haven't seen that many fibromyalgia patients yet at this clinic, but in the last few weeks, I've seen a couple, and there's also been more discussion at rounds with current research projects that are going on at our clinic with fibromyalgia patients in the microbiome. So as a result, I did more reading around this and around the historical changes in how fibromyalgia was diagnosed. And I noted that in early criteria, dermatographism was considered a sign, which has since been dropped, but this is often an exam finding in many MCAS patients. The overarching themes of pain, fatigue, plus or minus sleep issues have been what have persisted in fibromyalgia diagnosis. And what I found interesting reading about this at the same time as I was preparing this talk was reviewing the symptom severity score. Now, it's no longer recommended in the most up-to-date fibromyalgia criteria, as the expert consensus panel seemed to feel that these other symptoms were overshadowing the importance of considering a patient's widespread pain. However, consider this. Remember this table from findings most frequent in MCAS? Well, it just so happens they overlap almost perfectly with the symptom severity score. And I checked off boxes that crossed between the table and this one, but keep in mind, the boxes I did not check were still recorded in that characteristics study as being present in greater than 10% of patients. It just didn't make it onto that table. So humor me now, but what if the pathophysiology of fibromyalgia, which to date remains unknown, lies in the mast cell? Mast cells have a widespread presence after all. Now, normally a slide like this with lists of genetic mutations generally makes my eyes want to bleed, but let's just say that fibromyalgia patients have a specific cluster of one of these KIT mutations, and we just don't know what they are. Maybe it looks like this, and we just need to figure that out. So, food for thought. What if we took an exploratory cohort of patients that meet criteria for both fibromyalgia and MCAS, took a blood sample, took out their mast cells, and ran genetic sequencing on them? Are there somatic mutations in mast cells that would reclassify fibromyalgia as a clonal disorder? And if yes, is there an overlap in the mutational pattern? And what mediators do these mutations overexpress? I don't know, but it sure sounds like an interesting research question to me. So to close off, I'm going to leave you all with a couple of resources. This book, Never Bet Against Occam by Dr. Afrin, is a great resource for physicians, and the cases really do read like medical mysteries. Occam's razor is a concept he highlights in the book, which is a problem-solving principle stating that of possible solutions to a problem, the simplest one is usually correct. So in medicine, Is it more likely that a person has 12 diseases accounting for symptoms, or one that could rationally explain most, if not all of them? So it was supposedly written for the lay public, so patients could potentially learn about MCAS, but I will say this would be a difficult read for most of our patients for sure, that aren't at least university level. I did include Dr. Afrin's email at the bottom there, so if you have questions or want to ask about a case, seriously, I've never come across a more accessible specialist in my life. He's also willing to provide informal resources to those who ask for his starter pack. And anyone who frequents the pain clinic here, I have a copy of the book that I can lend you because I probably won't want to read about MCAS for a while after today. So it's definitely free and available. Now, this is a website for the Mastocytosis Society, which, although it's more directed towards systemic mastocytosis, still has useful resources as symptom management does overlap between mastocytosis and MCAS. This is a list of references of probably some of the most useful papers in MCAS published in the last 13 years from both camps, although certainly there's plenty more out there. And I'm happy to send it to anybody who wants them. I can send my folder PDF copies of all of these documents. Okay, so you've all survived, and now I'm happy to take questions and attempt to answer them, although I will profess I'm far from an expert on the subject.